Good morning, sir. I'm going to present about management of carcinoma esophagus, sir. And coming to the summary of my case, which was discussed previously, a 65-year-old lady with no comorbidities and chronic BD smoker presented with short duration progressive dysphagia, which was initially to solids and later progressed to liquids over 6 months, with associated loss of weight and appetite. She is poorly nourished with BMI of 16.3 and ECOG performance status of 2 with unremarkable neck, chest, and abdominal examination. And with the history, my provisional diagnosis is malignant dysphagia secondary to carcinoma esophagus and carcinoma of GE junction.
Sorry, I was not present last time, but we must have reached a final diagnosis after the imaging.
Yes, sir. Imaging was also over, sir.
Yes. So
Yeah.
what was the final diagnosis? Okay, you are going to present. Fine. Carry on.
Yes, sir.
Show us the blood reports also. Yes.
Yes, sir. In the her hemoglobin is normal, sir, with 12.4, and then counts were slightly elevated, 11.7, and then her urea was 58 because of the dehydration status, and then her sodium and potassium electrolytes were normal, and her albumin is normal, which is stating her malnourishment status, and her IPT and her coagulation profile is normal, and her viral markers were negative.
So if you say her urea is high because of dehydration, is there anything else that you would reconsider in this report?
Her electrolytes, sir.
Albumin is okay, 2.5. Actually, you can say that even that may be even lower than 2.5 because this is with dehydration. We haven't published it, but we have seen that in most patients with malignancy and especially advanced malignancy, the immediate preoperative serum albumin is always fallacious. It always falls down once the patient is properly hydrated during the anesthesia and surgery. Anything else which can be affected by dehydration?
Hemoglobin also, sir.
Yeah, so you should say that this hemoglobin of 12.4 may not be the actual or the correct hemoglobin. It may be hemo concentration. And what is missing here?
Hematocrit, sir.
Hematocrit. So all these things on your own, you should, when you are analyzing a report shown like this, you should say that I would like to have a look at the hematocrit also. Okay,
Yes.
carry on.
And then after that, I would like to proceed with the upper GI endoscopy, sir.
So while she's connecting, although
Yes,
the
sir.
patient did not give any history of comorbidities, but two things you have to keep in mind. One is the nutritional status because her BMI was low, albumin is low, she is dehydrated as reflected in the elevated urea, but normal creatinine. So hemoglobin also may be lower than 12. And we are thinking of a major surgical procedure. That is one. Second, she has been a chronic BD smoker. So although she hasn't given any history, but we have to keep that in mind. And in any case, all patients who are undergoing esophageal surgery, the lung function has to be evaluated, but here it becomes even more important. So in the preparation, as we will discuss later, evaluation of the pulmonary function, breathing exercises, orodental hygiene, looking for evidence of COPD, looking for any evidence of superimposed chest infection, looking for aspiration pneumonitis like in any other patient with dysphagia. All these things are important.
Can you see, sir, now?
Yes. Please carry on.
Yeah, sorry, sir. Sorry for the disturbance. And yes, sir. Yes, sir. So in these blood investigations, the HB must have been because of the hemo concentration, and the hematocrit value is not there over here. And followed by, shall I proceed, sir?
Yes, carry on.
And then followed by the upper GI endoscopy plus biopsy. In the upper GI endoscopy, the report stated that at 30 centimeters from incisors, growth is seen occluding the lumen. Scope is not negotiable beyond it. Guide wire passed beyond the growth under endoscopic and fluoroscopic guidance. RT was tried to insert but was not possible as growth is occluding the lumen. And then we have taken multiple biopsies from the growth. The biopsy report stated it is moderately differentiated squamous cell carcinoma. Okay, sir?
Yes, please carry on. I think all this we have discussed earlier.
Yeah, then I would like to get the ultrasound for the abdomen for the patient, which stated the liver is normal in size 12.5 centimeters. IHB are not dilated. Hepatic veins and portal venous radicals are normal. Gallbladder wall thickness is normal and lumen is echo-free. Minimal free fluid is seen in Morrison's pouch and in pelvis, and left-sided minimal pleural effusion noted.
Yeah, just summarize and give your interpretation, then we can move on to the management.
Yes, sir. So in the ultrasound report, it stated that there are no liver metastasis or any minimal free fluid is present, like minimal ascites is present in the ultrasound. So next, I would like to get one chest X-ray also to rule out pulmonary metastasis. The chest X-ray of the patient, which is grossly normal, and it is showing COPD changes because of the prominent bronchovascular markings. And
Haritha, would you prefer a CT or would you prefer a chest X-ray? What is the accuracy?
sir, actually, initially we'll do one simple chest X-ray, sir, because it is not expensive and it is big. In this chest X-ray, if there are any metastasis, we can directly start for the palliative treatment for the patient. And if we cannot find anything over here, we can go for chest X-ray of the. We can go for the CT scan of the chest and abdomen.
Okay. Okay.
So you should, did you say that it is a hyperinflated lung?
Yes, COPD, sir. COPD
yes,
is there, sir.
yes.
Yes. And then RCT.
So whenever you are showing any images, any reports, especially in a public forum, except your departmental meeting, you should always hide the identity of the patient.
Yes, sir. Sure, sir. And then the CT scan report stated that mild concentric smooth mural wall thickening is seen involving mid and lower thoracic esophagus, the thickness of 6 mm with proximal dilatation, involving approximately 10 centimeters long segment, possibly inflammatory thickening. They stated that it is less likely neoplastic. And no other abnormalities, no other lymphadenopathy is seen, and the lung fields are normal with no pleural effusion, and trachea and bronchi are also patent. This is the report, sir.
Yes, carry on. Okay. So does the length matter? It says 98 millimeter long segment.
Yes,
they have
sir.
said inflammatory, but we know that there is a malignancy because we have a positive histology.
Yes, sir. Because if the length of the tumor is greater than 6 centimeters, it will invariably go to three lesion. Like most probably, it can be T3, sir. When the length of the segment is greater than 6 centimeters.
Yeah, so the more accurate answer will be that length does not alter the stage. The stage is determined, the T stage is determined by the circumferential spread, not by the longitudinal spread. But in general, the longer the lesion, the more likely that it is advanced, higher T stage with infiltration of adjacent organs. And length is important more for...
Then basically, what how we get the length of this esophageal involvement in the CT scan? What length? They tell us the long length segment. How we can get to know?
Like if it is starting from 20 to 25, like in which view we can see, or how we measure, sir?
Like in the CT scan, we see the thickness each vertebra is one vertebral thickness, two vertebral thickness. Then we can predict that it's more lengthy. Otherwise, in the CT scan you can't see. And the CT scan you can also see the from the length from the starting point to, and the where it is finishing. But the easiest thing with the vertebral length we can predict what two vertebral length, one vertebral.
Oh, okay, sir. Okay. In the coronal view, we see the count in the vertebra, and then we can see the length.
So length is of importance to the endoscopist when they want to pass a guide wire, when they want to dilate, like a corrosive stricture. So for them, length is important. For us, it is not that important, except that it is an indirect indicator of the stage of the disease, not directly.
Yes.
Okay.
Haritha, how do you divide the esophagus?
Sir, we divide the esophagus into cervical esophagus, thoracic, sir. And then in thoracic, it is upper, middle, and lower esophagus, sir. And cervical esophagus is the one that extends from the cricopharyngeal sphincter to the sternal notch, which is of 5 centimeters in length. And then upper thoracic esophagus that starts from the sternal notch to the esophagus vein, which is 5 centimeters in length. And then mid thoracic, which starts from the esophagus to the lower part of the inferior pulmonary vein, which is again 5 centimeters. And from the inferior pulmonary vein to the GE junction, which is the lower thoracic esophagus of 10 centimeters in length, sir.
Yeah, okay. Good.
Yeah, but from surgical management point of view, the most important landmark for thoracic esophagus is the carina. So
Yes.
supracarinal lesions versus infracarinal lesions. In supracarinal lesions, you would carefully look for tracheal involvement. Infracarinal lesions, only in the upper part of the infracarinal region, there may be proximity and involvement of the left bronchus, especially. If it is lower infracarinal, then you are not worried so much about the tracheobronchial tree, but obviously you are worried about the aorta and the vertebral bodies. Okay,
Yes.
fine. So what is the final diagnosis after all the investigations?
Sir, this is the moderately differentiated squamous cell carcinoma involving the mid and lower thoracic esophagus, sir. In a
And-
patient with ECOG performance status of 2 and poorly nourished currently.
So what is your plan of management of this patient?
This patient, first, I would like to give her IV fluids as she is not taking anything orally. And then I would, to build up her nutrition first, I would consider feeding jejunostomy for the patient.
Is feeding jejunostomy the only option of nutritional support?
No, we have other also, so like we can put one nasogastric tube or nasojejunal tube endoscopically, but as it wasn't possible in this patient, I would consider feeding jejunostomy.
Let me go a step back. So you said you would like to build her up nutritionally, but what is your definitive management plan of this patient?
First, I would like to consider neoadjuvant chemoradiotherapy, followed by seeing the response of the patient to the chemoradiotherapy. I would like to consider her surgery.
So surgery is the only option of treatment in this patient?
Neoadjuvant followed by surgery. Like we have to do surgery later stage.
What is definitive
Carcinoma?
chemoradiotherapy? What is definitive chemoradiotherapy?
Squamous cell carcinoma of the esophagus, you can't say that surgery is the only option of treatment.
Yes, sir, not the only, but after chemoradiotherapy, we can go for surgery.
No,
Or
so that means you are considering surgery in any case.
No, actually, we can wait and watch policy is also there, sir, now, in case of squamous cell carcinoma, according to the Sano concept.
Go to your next slide. I think I saw something there.
Yeah, I just got the management the protocols, sir.
So for squamous cell carcinoma of the esophagus, it is not right to say that surgery with or without neoadjuvant chemo or chemoradiotherapy is the only option. Definitive chemoradiotherapy, which means that is the only treatment given, no surgery, is also an option. Squamous cell, adenocarcinoma, no. But squamous cell carcinoma of the esophagus, there are two options of treatment.
Yes, sir.
And same way, squamous cell carcinoma of the anal canal, actually definitive chemoradiotherapy is the preferred option because there the surgical alternative is an APR, which you would not do as the first management. Same way in lymphoma of the GI tract, unless there is a risk of impending perforation, chemotherapy is the treatment of choice. Of course, it carries the risk of perforation, but still, theoretically speaking, it is the treatment of choice. So there are certain malignancies where non-surgical treatment is the either treatment of choice or is a definite option. So for squamous cell carcinoma esophagus, you have to say, and in fact, for cervical esophagus, and some people say even for upper thoracic esophagus, they prefer chemoradiotherapy rather than surgery for various reasons. Okay.
Yes.
So in this case, why do you not want to offer definitive chemoradiotherapy? Because if that is the treatment, the oncologist may think that, okay, simultaneously we will give nutritional support, but we will start the treatment.
Yes, sir. But as the growth is involving predominantly mid and lower thoracic esophagus, I would also like to consider surgical option for the patient after neoadjuvant, sir. Because after definitive chemoradiation, we have to keep the patient for close follow-up. And if there is a chance of recurrence also, and after recurrence, the salvage surgery will be difficult for the patient.
So 2 or 3 things. Now, students, please remember, send me a mail, vkkapoor.india@gmail.com. I'll send you an article which I think Dr. Kailash Kudia has written with me on, or maybe Dr. Murugappan. on the role of chemoradiotherapy in various settings, definitive, neoadjuvant, adjuvant in esophageal cancer. So he has very beautifully summarized all these points, some of which I am going to make now. So one is that, as I said, that squamous cell carcinoma esophagus, you have both the options. Higher the tumor, which means cervical or upper thoracic, you tend to go more towards definitive chemoradiotherapy. The literature says that definitive chemoradiotherapy can give almost the same results as surgery with or without chemoradiotherapy. This is all for squamous cell carcinoma we are talking.
Yes.
When you give definitive chemoradiotherapy, the dose of radiotherapy is different as compared to what you give in neoadjuvant. So you have to decide to begin with what your plan is. Is it neoadjuvant or is it a definitive? Because definitive goes up to, I think, almost 70 gray. Rajendra, am I correct?
65 guides, sir.
Yes. Yes. Yeah. So it is higher than neoadjuvant. Third is that you have to see, you have to follow up, and that we will discuss that how do you follow whether the tumor has disappeared or not. So whether there is complete response or not. If there is no complete response, then you can then offer surgery, which is known as salvage surgery, like salvage transplant in HCC. So it is called salvage esophagectomy. And in that review, we have mentioned that whatever little evidence is available, salvage surgery does not have poorer results as compared to surgery upfront. So it is an option. Okay. So can you, okay, you were going to discuss neoadjuvant. First, tell us about neoadjuvant therapy and then tell us about definitive chemoradiotherapy.
Yes, sir. In neoadjuvant therapy, as it is squamous cell carcinoma, I would like to consider the cross trial, sir. So where we give carboplatin and paclitaxel plus concurrent radiotherapy with 41.4 gray radiotherapy, which is usually given in 5 cycles, sir.
How do you assess the response to neoadjuvant treatment in esophageal cancer?
The response is assessed actually first clinically, sir, the symptoms of the patient, and then we should get the same imaging of the patient which we have done preoperatively, radiological investigation, which is usually PET CT scan is preferred in case of squamous cell carcinoma as their FDG avid, and then endoscopic biopsy.
So you should say clinical, endoscopic, imaging, biological. PET is a biological imaging. You can do PET also, and histological, which is biopsy. And to show complete response, all of them. And in case of pancreas, you could say tumor marker also. Here, of course, there is no tumor marker. So all these should be negative before you label the patient as complete response. And same thing you use when you want to follow the Haber-Gamma regime in carcinoma of the rectum. All these parameters have to be fulfilled.
Okay, sir. Yes.
And as we mentioned, that definitive chemoradiotherapy, the regime is same, but the dosage and duration is longer.
Yes, sir. And it is more at.
Yes. Okay. So now going back to suppose your plan is to offer surgery. You said nutritional buildup and you wanted to do a feeding jejunostomy. What are the other options you did mention?
About the endoscopic nasogastric tube or nasojejunal tube, sir.
So in this case, guide wire could be passed or could not be passed?
RT couldn't be passed, sir.
But guide wire was passed.
Yes, the guide wire was passed, but then
that's little unusual because once guide wire is passed, then some tube can definitely be passed. Suppose guide wire has passed, but tube cannot be passed. What other option do you have?
We can actually destroy the tube, like coagulate the tumor, sir, and dilate the tube.
Yeah. So one is that you can dilate. Once guide wire is there, you can easily pass a dilator over it, especially a balloon dilator. You can dilate the tumor, although theoretically speaking, there is a risk of rupture and perforation. You can ablate the tumor to create a passage using whatever ablative measures, including cautery, including RFA, including laser. Even radiation can help. You give one or two doses of radiation, and that can cause the tumor to, the tumor can become less and you can dilate. So, endoscopic placement of a feeding tube is also an option
Yes.
here. And if the patient doesn't want a tube, suppose you anticipate that you are going to take 2 weeks or 4 weeks to build up the nutritional status, then you should also mention that placing a stent is an option, although it is an expensive option, self-expandable metal stent. But if the patient can afford, because the stent will then come out with the specimen, it doesn't create any problem in surgery, and it obviously achieves a larger lumen, and there is no tube. So these are all various options of providing nutritional support. What about total parenteral nutrition?
Total parenteral nutrition giving for long duration like 6 weeks. It is generally like the patient will have again the electrolyte imbalances, and
So those are the problems, but what is its role? What is in general, what is the role of total parenteral nutrition as a build-up of the nutritional status of the patient before a definitive surgery for any malignancy?
we can give total parenteral nutrition, sir, like through TPN or as a bridge therapy. Like we can give total parenteral nutrition. TPN we can give, sir, but the thing is it's expensive, and it has
even before the cost and the possible complications, the answer is that most of the evidence is not in favor of total parenteral nutrition as the nutritional support. It is always enteral nutrition which is preferred. So most groups probably would not use total parenteral nutrition as the nutritional support for building up the patient for a major surgery. Okay.
May I interrupt, sir?
Yes, Rajendra.
Yeah. How effective is nutritional therapy in building up a patient with cancer? What are the things that work against us when we're trying to build up a patient with cancer with nutritional therapy?
The tumor which is there from the resectable stage, it can progress and then it can go to unresectable stage. Like one of the disadvantages that is present.
That's not my question. When you give nutritional therapy in a normal patient, say for example, a patient who has not been eating well for whatever reason because he has gastroenteritis, and we build him up, versus a patient with cancer, how easy is it to build up a patient with cancer? How long do you have to wait before they're built up sufficiently before you can say, I will take up for surgery?
Like minimum, we have to see the parameters, various parameters. Like first, we have to see the patient's skin fold thickness, which are the signs of malnourishment, and we have to see the albumin levels again of the patient.
Are they all going to become normal? In cancer patients, it's remarkably difficult to build them up because they have what is called as cancer cachexia syndrome, where because of necrosis factor alpha and interleukin 6 and interleukin 4, there is an inflammatory state. So whatever nutrition you give is not as effective as in a normal patient with a non-malignant cause of obstruction. Say, for example, a corrosive stricture. And you have to give 6 weeks to 3 months duration of nutritional therapy before you can build them up sufficiently. And that you cannot do in a cancer like esophageal malignancy. You can give them, you can hydrate them because you are going to give them cisplatin and paclitaxel. So you have to hydrate them well. You start definitely chemoradiotherapy and you continue nutritional therapy. That is more effective in supporting a patient rather than aiming to improve the nutritional parameters. Nutritional parameters do not improve.
So the better answer to Dr. Desai's question could have been that the two important causes of malnutrition, especially in a patient with esophageal cancer, are poor intake and cancer cachexia. Cancer cachexia is irreversible. As long as cancer is there, you cannot take care of it. But whatever part of the malnutrition is because of the poor intake, that you may correct to some extent. And that is why, as Dr. Desai said, that it is not that you give adequate calories and adequate proteins for an adequate period of time and all these patients will come back to normal nutrition. That never happens because there is a component of cancer cachexia. Okay. So we have given neoadjuvant treatment. We have assessed the response. When do you want to? So how long does the neoadjuvant treatment last?
5 cycles will give, sir. So each per week. So 5 weeks, like 4 to 6 weeks, sir.
The radiotherapy lasts for
Five
it's 45 gray, isn't it?
Yes, sir. 41, 45.
Hmm.
So 5 times a week we give, sir, for 5 weeks, sir.
Yes. And when do you want to operate?
So first, before surgery, like we'll wait for 4 to 6 weeks, sir, and then we'll again assess the response of the tumor to the treatment, and then we'll plan for the surgery.
So suppose there is good response and suppose there is no response or maybe even progression of disease. How does it change your plan?
If there is a progression of disease, we'll go for the efferent surgery, sir. Like we'll withdraw the chemoradiotherapy that is going on, and then we'll immediately go for the surgery, efferent surgery. And
Haritha, you should say that if it is a resectable lesion for which you have used neoadjuvant chemoradiotherapy, progression is an indication of bad biology.
yes, sir.
If it is resectable, we can still resect it. But in a lesion that is borderline resectable, you would not prefer to do resection because their biology is inherently bad.
Yeah.
Yes.
Post-operative adjuvant will not work. So the chance of recurrence of the lesion after subjecting them to the risk of surgery, which will delay chemoradiotherapy for an additional 6 to 8 weeks, which will be bad for their prognosis, you would prefer to change them onto a definitive chemoradiation, or you need go for something like proton beam therapy to try and tackle the tumor.
Okay.
You should not do surgery because they are not responding to neoadjuvant chemoradiotherapy. This
So
is not true of
response-
carcinoma of the esophagus.
Response to treatment is a very strong and very good indicator of the outcome of surgery. Patients who respond well to neoadjuvant treatment, they do best. And that is why some people insist that even if there is complete response after neoadjuvant treatment, you should still operate upon the patient and remove the esophagus, even if the endoscopic biopsy is negative, because these are the patients who will have the best outcome of surgery. On the other hand, as Dr. Desai pointed out, that if there is no response or worse still, if there is progression of the disease, one thing is very important, that you must reevaluate the patient. So there are two schools of thought. There are people who would say that all patients who receive neoadjuvant treatment, they must have a reevaluation before surgery. That is the ideal. So you do everything. You do CT, you do endoscopy. Some people would even do PET just before surgery, although all this has been done before neoadjuvant treatment was started. The other group is that when you want to conserve on the investigations and costs, that if it was a resectable lesion to begin with, but you gave neoadjuvant treatment and there is clinical and endoscopic response, you may not do a CT and PET because very unlikely that the patient will have metastasis. So if there is no response and if there is progression of disease, even if you believe in this limited reevaluation, you must reevaluate the patient to see whether it is resectable and to see whether metastases have occurred. And even if it is still resectable, as Dr. Desai said, this is the subgroup in which the outcome is going to be poor. So some people may not operate upon these patients. Although technically it is resectable, but poor response to neoadjuvant treatment is an indicator of poor outcome after surgery. So in that case, the option is to convert the neoadjuvant into definitive. But the problem is you have already had a 4 weeks gap because you don't reevaluate immediately after completion. And most radiotherapists, they don't like this gap. So you have already given 45. Now we tell them that give 20 gray more, but they don't agree with that. So the other option is to continue only chemotherapy or you use another regime of chemotherapy. But the basic principle is that non-response or progression of disease in spite of neoadjuvant treatment is a very poor indicator of outcome of surgery. Okay. Okay, so let's come to surgery then. What surgery? Suppose we have provided her nutritional support, she has responded, her albumin. What albumin would you target for surgery? At 2.5, now would you operate?
No, sir. Minimum is 3.5 or 3.5 or greater than 3.5.
Ideal would be 3.5, but I mean, even 3, but less than 3, everybody would probably be skeptical. Okay. And some weight gain, which may or may not be achieved, as Dr. Desai pointed out. Okay. So what surgery you have in mind in this case?
For this,
This case, sorry, let us recollect. What is the relationship of the upper end of the tumor to the tracheal bifurcation?
sir, it is starting immediately after the bifurcation of the trachea, sir. After the bifurcation of trachea.
And there is no suspicion of involvement of the tracheal
Involvement.
tree?
No, sir.
Okay.
Or
Okay,
any
fine.
to
So
left.
what surgery do you have in mind in this case?
Here we usually do three-phase McKeown's hybrid esophagectomy with the gastric conduit, sir, with cervical esophagogastric anastomosis and with the feeding jejunostomy.
Good. I'm very happy that you gave a complete answer. So whenever you are asked what procedure you will do, especially for an esophageal or G junction cancer, you should say which approach. So whether it is a cervical thoracic abdominal approach, whether it is thoracic and abdominal approach, whether it is thoraco-abdominal approach, or whether you are doing an open or minimally invasive, what is the extent of esophagectomy, what is the extent of gastric resection in case of a G junction tumor, what is the extent of lymphadenectomy, you didn't mention that, but you should have. And yes, what conduit you will use and where you would do the anastomosis and what technique you will use for anastomosis. That is the complete answer when you are asked what procedure you would do. Okay. So let's discuss one by one. You said McKeown approach. What is McKeown approach?
The McKeown approach is where we first start with the thoracoscope. It's McKeown thoracoscope, chest thoracoscopy plus laparotomy plus cervical anastomosis, sir.
मैक्यूअन ने जब डिस्क्राइब किया था तब तो शायद थोरैकोस्कोप नहीं था.
Okay, sir. Thoracotomy.
The original is
Thoracotomy.
cervical incision, thoracotomy, and laparotomy. Of course, we have now modified that to thoracoscopic and laparoscopic. Okay, fine. What are the other approaches for doing esophagectomy?
Usually for the mid and lower thoracic esophagus, we can go for transhiatal approach also, sir, which involves only the abdominal and the cervical anastomosis, sir.
Whose name is attached to transhiatal?
Yes, sir. Oringer transhiatal approach.
Oringer, yes, Oringer. And any other approach?
Ivor Lewis is also there, where we give thoracotomy and abdominal, sir, and the anastomosis is in the thoracic anastomosis.
And one more I mentioned, not very frequently used, but thoraco-abdominal, left thoraco-abdominal.
Thoraco-abdominal approach, sir.
Yeah. So what are the advantages of all these 4 approaches which we mentioned, and what are the disadvantages?
First, with the transhiatal approach, sir, this is the one which is most commonly, as I said, for the mid and lower thoracic esophagus. The survival benefit for both the
actually not even for middle. You should say for infracarinal.
Yes, sir. G junction and lower thoracic esophagus.
Most people would not use it for anything which is in relation to the carina or the trachea. So it's mainly for lower thoracic and G junction tumors.
The survival benefit is equal, but then here we can clear only the infracarinal group of lymph nodes and the abdominal lymph nodes. So if the tumor is involving the mid, in case of Ivor Lewis, if the tumor is involving the mid and upper thoracic esophagus, we can directly visualize the tumor and we can do the dissection, and the lymph node mediastinal lymph node clearance will be better for the in this approach. And
so about the Oringer's transhiatal, when Oringer described it initially, it was also called blind esophagectomy because the dissection of the thoracic esophagus was done with fingers introduced through the neck and introduced through the esophageal hiatus, and there was no formal lymphadenectomy. But as the technique evolved, now by either enlarging the hiatus, by dilating or even dividing the crust, and especially using a telescope, a laparoscope, you can do this dissection, at least in the infracarinal part, under vision. So it is no longer called blind. And that is why the infracarinal node dissection can be done with a transhiatal approach also. Obviously, you can't do a suprahiatal. And as you rightly said, if it is either Ivor Lewis or McKeown, because you are into the chest, you can do the entire mediastinal, posterior mediastinal lymph node dissection using these approaches. The difference is that in McKeown, the anastomosis in the neck. In Ivor Lewis, it is in the chest, but in the supracarinal, at the apex of the thoracic cavity. And thoracoabdominal, I mentioned, not very frequently used, not by many people, but for a GE junction growth, the conservative surgeons who would do a partial esophagectomy and a proximal gastrectomy, they can do it. So you use a thoracoabdominal approach, you go into one of the lower intercostal spaces, extend the incision in the same line across the costal margin, dividing the costal margin into the abdomen, going up to the umbilicus. Then you divide the diaphragm so that the two cavities, thoracic and peritoneal cavity, become one. And finally, the anastomosis is in the chest, but it is infracarinal because you are approaching from the left side. As I said, not many people prefer to use it, but it is one of the options. What are the differences between cervical anastomosis and thoracic anastomosis, pros and cons?
Cervical anastomosis, as the anastomosis in the neck, though the leak rate is higher compared to the thorax, the management, how we manage the leak is much easier when compared to the thoracic anastomosis, which has even though low leak rate, but if at all it leaks, it leads to dangerous complications like mediastinitis, which are difficult to manage from our part.
Yeah, so you were right. The risk of leak is more in neck as compared to in the chest, but it is easier to detect because there is a wound, and in fact, many people leave the lower part of the wound open. This is what our practice was. This was started by us when Dr. Ibrarullah was with us, that instead of leaving a drain, we used to leave the lower 1/3 of the neck incision open. So if there is a leak, it becomes obvious clinically. You can give methylene blue and you can see whether it is coming out. And the consequences of a cervical anastomotic leak are much less dangerous than the consequences of a thoracic leak, because that will inevitably lead to mediastinitis, which is a very severe sepsis with high mortality. The only problem is that if the cervical leak is posterior, not anterior, and then it is not easy to detect, it can trickle down into the mediastinum and have the same consequence. So that is one of the kind of side advantages of a McKeown or a transhiatal approach, that you end up doing a cervical anastomosis. What are the disadvantages of a cervical?
Injury, like when we do cervical in the cervical dissection, there is a chance of injury to the recurrent laryngeal nerve, which can lead to the hoarseness and then chance of aspiration, pneumonitis.
Any problem of thoracic other than the consequence of leak of thoracic anastomosis, which is usually not there in cervical anastomosis?
In thoracic anastomosis, like usually we try to preserve more length of the esophagus. So radicality is compared to the three-phase, it is less.
So how much margin you require in when you are operating on the esophagus?
In case of squamous cell carcinoma, proximal margin should be 10 centimeters, but for adenocarcinoma, 5 centimeters is adequate, sir.
Yeah, so that is why for squamous cell carcinoma, most surgeons would prefer to do it is called total, but it is not total, it is a subtotal esophagectomy, because you preserve a few centimeters of the cervical esophagus for anastomosis. And that is the reason, because there is always the chance of submucosal lymphatic spread, distant spread, and also multicentricity. Whereas for adenocarcinoma, so thoracoabdominal approach is only for adenocarcinoma of the G junction, not for squamous cell carcinoma.
Yeah, and also in thoracic anastomosis, as we place the stomach in the negative intrathoracic pressure, there is the chance of reflux also more.
Reflux is always more in thoracic anastomosis as compared to a cervical anastomosis. Rajen, you want to add something?
Yeah, Haritha, in your evaluation of the patient, you did not mention anything about a PFT. Pulmonary function assessment, cardiorespiratory assessment is a critical part of assessment for carcinoma of the esophagus.
Yes, sir.
Here,
Yes.
the lungs are abnormal, and without a PFT, if you proceed, you could land in serious trouble.
So we got it done for the patient, and she could not do the PFT, sir, actually. And
Yeah,
cardiac,
so does that mean she is fit for surgery?
no, sir, no. So that's
So your options are already silenced.
yes,
So
sir.
you cannot do surgery on her because she has bad lungs.
Yes, sir.
She is a BD smoker, and it is unlikely to be reversible because it's an emphysematous chest. So you have to give her definitive chemoradiotherapy. You don't have an option really.
Yes, sir.
So this is very important. In the examination, if you don't get this investigation, you have to specifically ask for it.
Yes, sir.
You say, I want to know the PFT because that will help me assess whether this patient can be operated or not.
Yes, sir.
So for
as,
this patient, it is definitive chemoradiotherapy.
as a routine in the exam as well as in your clinical practice, all patients who are being considered for a possible esophageal surgery, and especially if the patient is elderly smoker, you must do a PFT and you must even do an arterial blood gas, ABG. And if these functions are not optimal or they cannot be optimized, then as Dr. Desai said, in addition, there is poor nutrition. I would also be very skeptical to consider surgery for a patient like this, especially when there is a option, equally good option, as literature says, of definitive chemoradiotherapy. Brief. So in this case, suppose she becomes fit for surgery or she was fit for surgery. You said McKeown approach using thoracoscopic and laparoscopic.
Laparotomy, which we do in our center, sir.
Why laparotomy? Why not laparoscopic?
We can, it depends on the surgeon's choice, sir. We can proceed for.
If you can do thoracoscopy, you can do laparoscopy also. So describe in 10 lines how you do McKeown esophagectomy.
Here, first we proceed thoracoscopically, sir. We first general anesthesia. We give the patient general anesthesia with epidural, sir, in a trolley beside the OT table, and then we place the patient in the prone position on the OT table. After adequate
So
position,
is prone the only position?
so we can. People do use left lateral decubitus also, sir.
Yes.
And after positioning the patient in prone, we usually place sandbags under the chest and under the pelvic region. And we keep the right shoulder 90 degrees abducted. Following that,
So I said 10 lines. If you describe all these minor things, you will consume your 10 lines in this. So depends on question. If I am saying 10 lines, which means I am not interested in all these small things. Chalo, carry
first,
on.
sir, 3 thoracoscopic ports, sir. And then after that, we first check the esophagus resectability. We check the resectability of the tumor. We check. And then we start the dissection. First, we'll incise the inferior pulmonary ligament so that lungs will fall backward. And then we'll carry it up to the pericardium caudally. And then we'll proceed cranially up to the pulmonary vein. And then followed by that,
Which
we'll
vessel is divided in the chest?
esophagus vein, and then we'll incise the pleura, and then we'll ligate and divide the esophagus vein. After division of the esophagus vein, we'll proceed to the pericardial dissection, and then we'll take care of the thoracic duct. Anything between the esophagus and the aorta, we'll see thoracic. We'll see for the thoracic duct, and then we'll safeguard it, and then circumferential mobilization of the esophagus from the hiatus to the thoracic inlet will do.
Only the esophagus?
The adjacent lymph nodes also, sir. Lymphatic.
All the peri-esophageal posterior mediastinal loose areolar tissue, including the lymph nodes.
Yes, sir.
Then?
That esophageal, after the completion of the esophageal mobilization, Then we'll proceed to the abdominal part through the midline laparotomy incision.
Is there any situation where you would prefer to go in the abdomen first than in the chest?
Where the tumor is involving more on the lower, like G junction and the lower esophagus.
Is it the location or is it something else? It is the histology. Adenocarcinoma is more likely to have liver or peritoneal metastasis as compared to squamous. So if you are using this approach for an adenocarcinoma of the GE junction, most people would prefer to do a staging laparoscopy first
Yes,
to
sir.
look for surface deposits on the liver and peritoneum, because if they are there, then in all likelihood you would abandon the procedure unless you believe in proceeding with resection, especially if there are oligometastases. Few small metastasis close to the primary tumor, that is the definition of oligometastasis. So this concept is coming in literature that in a good risk patient, in a nutritionally well-preserved patient, you may proceed with resection of the primary and the metastasis in presence of oligometastasis. So that is one situation where you would do the abdomen first. Okay, please proceed. What do you do in the abdomen?
After after giving the midline laparotomy incision, we'll start the mobilization of stomach first with the gastrocolic omentum, and then after opening the omentum,
But all vessels are divided to mobilize the stomach.
We'll divide left gastric vein and left gastroepiploic, and we'll safeguard the right gastroepiploic and right gastric vessels.
So you divide only the left gastric vein, not the artery?
Left gastric vein and artery, sir.
So say left gastric vessels.
Left gastric.
Left gastric. Where do you divide the left gastric vessels?
Along the lesser curvature, approximately 5 centimeters away, or exactly near the lesser curvature.
So you divide the left gastric vessels, especially the artery, as close to its origin, so that you preserve the division of the left gastric artery into the ascending and descending branch. That is what will supply the tip of the conduit, because you are preserving the right gastric vessels, you are preserving the right gastroepiploic vessels, and through this arcade, which is obviously more prominent on the greater curve, but there is some communication on the lesser curve also. That is why you always divide the left gastric before or proximal to its bifurcation into the ascending and descending branches. And then obviously you have to divide the short gastric vessels also. Okay, last question. How do you do the anastomosis in the neck?
Anastomosis, we do usually end to side, single layer, interrupted, and then with mostly 30 PDS.
That's the only technique.
We can do side to side also, sir, or end to end.
End to end. उसका तो end कुछ है नहीं, वो तो opening तो बनानी ही पड़ेगी. तो side, stomach का तो हमेशा side ही होगा.
Yes,
stomach का तो end नहीं है ना, end तो बंद कर दिया है.
Side
So, hand sewn is the only way you can do the anastomosis.
Staple anastomosis is also there, sir.
So when Oringer started with transhiatal, it used to be hand sewn, but later on he switched to stapled anastomosis. What are the prerequisites for a stapled esophagogastric anastomosis? What is
both the ends should be parallel, like the stomach and the esophagus should be parallel, the ends, so that we can insert the stapler.
Parallel, and they should be overlapping. At least for that much length as you want the stoma, because it is a side-to-side anastomosis. So one limb of the stapler goes into the divided esophagus with the open end. The other end goes into the stomach, where you make a separate opening for introducing the stapler.
Yes.
So there has to be an overlap. It cannot be that the stomach is coming just to the tip. If the stomach is coming just to the tip of the esophagus, you can't do a stapled anastomosis. You have to do a hand sewn anastomosis. Rajen, anything you want to add before we close?
I think she did good.
So again, students, please send me another mail. So first is for the role of adjuvant and neoadjuvant chemotherapy. The other mail you send where you write CASO. So I will send you the chapter on esophagus from the operative surgery, where some more questions have been addressed in relation to various approaches, transhiatal, transthoracic and others, and the complications. Okay. Thank you. Thank you, Haritha. Thank you, Rajen.
Thank you, sir.
Thank you, sir.